Okay, well, thank you for tuning into this week's PGY2 Pain and Palliative Care webinar series. Again, we're thrilled and honored to have Dr. Brad Ray leading our discussion this morning. Just as a reminder, we are being recorded, so I will mute and I will turn it over to Dr. Ray.
Thank you, Dr. Herndon. Today I will be talking about anticoagulant use in hospice. So I guess before we start, an important thing to understand is kind of how the body goes through the coagulation process and the clotting process. I'm going to go over this very briefly. Essentially what happens is there's two different mechanisms. There's primary hemostasis and secondary hemostasis. So primary hemostasis, essentially when an injury occurs, the body goes through a process causing vasoconstriction to prevent blood flow or to decrease blood flow from getting to the area where the injury is, and then a platelet plug occurs. That platelet plug activates secondary hemostasis, or what we call the intrinsic and extrinsic pathways, which eventually leads to the development of a fibrin clot. So as far as the intrinsic pathway, it is usually activated by trauma inside the vascular system and is activated by the platelets in the platelet plug. It's exposed to endothelium, chemicals, and collagen. This pathway is typically slower than the extrinsic pathway, but typically thought of as being important as well, if not more important. As far as the extrinsic pathway, it is activated by external trauma that causes blood to escape from the vascular system. So going into the clotting cascade, the coagulation cascade a little bit, I will first send out thanks to Dana Wright for letting me use her little diagram that she had made. So essentially what happens is, from the secondary hemostasis point, there's damage to small blood vessels or capillaries, and then it activates factor 7A and tissue factor. Now, 7A and tissue factor are important because they go on to activate the extrinsic pathway and the intrinsic pathway. The extrinsic pathway, both of them activate factor 10A, which is important, and they both meet at factor 10A. You can see from the pathway to form the common pathway where the pathways meet. Factor 10A is then further led to activate thrombin, which will activate fibrin. Fibrin is needed for the clot to occur, which you can see there. There's another pathway, or the third pathway, and this activates factor 9A, which serves as a kind of an amplification pathway for very severe injuries or during very severe hemostatic changes. So that's a overall view of the coagulation pathway, which will play a somewhat important part in understanding of the medications I will talk about. So as far as the clotting factors that are in the body, you can see we have a number of procoagulants and a number of anticoagulants. You can see for the procoagulants, we have 1 through 13, and the anticoagulants, we have protein C, protein S, and antithrombin. And these are all endogenous clotting factors within our body, which I will go over a little bit more when we start talking about some of the medications and which factors and proteins they actually affect. So as far as indications for anticoagulation treatment, we typically think about it for atrial fibrillation, treatment of a pulmonary embolism or DVT, or what we call VTE, prophylaxis for those, or stroke prophylaxis, which goes into atrial fibrillation as well. Also, it can be used for just stroke prophylaxis without atrial fibrillation. So here's a list of the most common anticoagulants you're going to see. So we have warfarin or Coumadin or Jantobin, heparin, Enoxaparin, dabigatran, rivaroxaban, apixaban, and edoxaban are all NOACs, or new oral anticoagulant agents, which I'll talk about, which aren't necessarily in the most up-to-date guidelines because they are relatively new. They are still brand name. So as far as warfarin, typically it's used to prevent or treat a VTE. And the mechanism of action, essentially what it does is it prevents the production of vitamin K active clotting factors by depleting functional vitamin K reserves. And now it affects quite a few different factors. You can see factors 2, 7, 9, and 10, protein C, and protein S. So looking at that, essentially which factors it affects are the ones that are highlighted here. So 2, 7, 9, and 10. So those are going to prevent clotting. Now, the problem with warfarin is when you first start it, it also inactivates our body's own endogenous anticoagulants, protein C and S. And this kind of goes into the whole bridging aspect that when you actually start warfarin, you're at an increased risk for clotting because protein C and protein S have a shorter half-life and are inhibited first before the procoagulants factors 2, 7, 9, and 10 actually become inactivated as well. So moving back to warfarin, essentially the goal INR is typically 2 to 3 in these patients, which we will do depending on the frequency. The frequency typically depends on the indication and patient-specific factors. Typically, we can't have a goal of 2.5 to 3.5, but it's only in mechanical mitral valve replacements. So 2 to 3 is a pretty typical goal of what we'll see. As far as warfarin, there are some clinical pearls I'll talk about. I'm not going to get into it too much because I don't want this presentation to take a super long time. But one thing to realize is that it takes a while to reach steady-state INR. Typically, we think about 5 days, but it's really independent, and it's independent or it's dependent on individual patient characteristics. Another thing to realize is that food affects the INR. So typically we think about our green leafy vegetables. They can have a decrease on the INR because they are a source of vitamin K. There's also many drug interactions. A lot of ones we think about are antibiotics, so Bactrim, fluoroquinolones, metronidazole. These all increase INR. Another one that we often think about that's not an antibiotic is amiodarone. Now this one, amiodarone has an extremely long half-life. So if they've been on amiodarone for a very long time and you start warfarin, it wouldn't expect to have a big increase. But if you are a new start amiodarone, it will have an effect on the INR, but it will take a while to see that effect. Some other drug interactions that actually decrease the INR, things like rifampin, St. John's wort, and sucralfate. Liver enzymes is something important to realize with warfarin because it does go through the liver process. So it is metabolized by CYP2C9, or at least the racemic mixture S form is metabolized by 2C9. Now, as I said, it is a racemic mixture. There's the S and the R warfarin. The S warfarin is what I'd call super warfarin because it's the more potent form and it is metabolized by 2C9, 1A2, and 3A4. The other R form of warfarin isn't metabolized by 2C9. It's actually 1A. It's by a different enzyme, but it isn't as important because it's not as influential in the therapeutic effectiveness of warfarin. As far as the bridge therapy goes, that's what I kind of mentioned earlier with those procoagulants that get inhibited by warfarin when it first starts. So typically we see it in the hospital. When patients are a new start warfarin, we'll use something else like Lovenox or Heparin to bridge them over since they are at an increased risk for clotting. Now, these patients typically need INR monitoring when they are in warfarin to assess the effectiveness. The good thing about INR monitoring, especially like in palliative care and hospice, is they do have point of care INR testing. So it doesn't mean that patients necessarily need to go get blood draws to get their INR tested. Nurses can go to patients' houses, much like a blood glucose, and test it right there, which is not only convenient for the patient, but also convenient for the hospice or the facility. And as I said, it is a racemic mixture of S and R, with S being the more potent warfarin. So another medication that we consider an anticoagulant is Enoxaparin. It's typically used for VTE prophylaxis and treatment. Mechanism of action, it's an anti-factor 10A inhibitor, and it also has antithrombin activity. And there's a few things to realize about this medication. One, that the dose and frequency are dependent on indication, renal function, and sometimes weight, depending on what the indication is. So when you're using it for prophylaxis, it's pretty standard. But when you come into actually treatment with this medication, you typically do a weight-based treatment, which you would see more likely in the hospital, but sometimes can be outpatient. Now, this medication is expensive, so that's something to realize and something important to understand. Heparin is another medication usually used for VTE prophylaxis and treatment. It works by potentiating antithrombin 3 and preventing fibrinogen to fibrin. So antithrombin 3 essentially is it causes inactivation of thrombin. So this also has some differences in dose and frequency depending on the patient's weight, renal function, and monitoring parameters. And when I say monitoring parameters, I'm talking about anti-factor 10A and APTT monitoring. The way we initially start dosing heparin doesn't have to do with that, but subsequent doses usually are monitored by either anti-factor 10A or APTTs, depending on when the actual monitoring takes place or what happens at your facility. So both of them are good. Usually anti-factor 10A is more preferred in facilities because it has been shown that you don't need to do as many draws. You get to a therapeutic level quicker, and you stay within therapeutic level for a longer period of time. So many facilities are starting to use anti-factor 10A for monitoring. Another thing to realize is that enoxaparin can actually be monitored with anti-factor 10A as well. It's typically not used in patients that are prophylactically dosed. Where you'll most often see it are in very obese patients that are on therapeutic doses for a pulmonary embolism or a DVT of some sort. You can do anti-factor 10A monitoring in those patients to make sure you're at a somewhat therapeutic level. So now I'm going to talk about the NOACs, or novel oral anticoagulation agents. So the first one I'm talking about is Pradaxa, or dabigatran. So this is used for non-valvular atrial fibrillation, treatment of VTE, or prevention of VTE. It is a direct thrombin inhibitor. And there are different dosages, and this is one of the first novel oral anticoagulation agents. One thing unique about it is about 6 months to a year ago, it came out with a reversal agent, idarucizumab or Praxbind. Now, this is a very expensive medication. However, there are very few side effects with it because it is a monoclonal antibody. It has a very short half-life. It does reverse the agent very well, and it is right now the only reversal agent for the NOACs. Now, with things like warfarin, we have vitamin K that can be used to reverse it, or Kcentra. We have different options in actually reversing warfarin. Dabigatran is another one that now we can reverse. Now, the other agents, we don't have a lot of good options. If you need to reverse them, typically it's a blood transfusion that you would give to help reverse it, to kind of unconcentrate the medications in the blood. Some of the other ones, rivaroxaban, apixaban, and edoxaban, they are similar to dabigatran. They don't have reversal agents, but you can do blood transfusions, etc., if you do develop a bleed or something of the sort. And these are not direct thrombin inhibitors, rather they're factor 10A inhibitors. So they can be used for both DVT and PVE treatment or prophylaxis. Typically for the prophylaxis, it is used post-operative hip and knee surgeries, or if they've had a PE event, they would use a dose for about 6 months as prophylaxis to prevent another PE or a DVT at a lower dose than what you would do for treatment. So what are some considerations that we have to think about before choosing an agent or thinking about an agent? So renal function is one of them, and essentially every medication that I mentioned previously has to do with renal function and needs to be dose adjusted in renal impairment. Now, warfarin is an exception, although it is noted that patients are at an increased risk typically of bleeding when they do have severe renal disease. So not that it has a direct effect on warfarin and needs to be renally dose adjusted, but you should take it into consideration. Hepatic function is another thing that should be assessed and should be looked at before starting these medications, because a lot of them have not been studied in hepatic dysfunction, especially child Pews classes B and above. And warfarin is metabolized in the liver, so that's something else important. Not only that, but our clotting factors are assessed or are produced in the liver, so it can have a big effect on our different clotting cascades. So BMI, or body mass index, that's another thing that we need to look at, and especially important for Enoxaparin, because that's how we dose it when it comes to treatment. We look at the BMI typically and renal function to assess what the appropriate treatment dose would be. As far as age goes, that's going to be more so clinical judgment, but when patients age, we know they are at an increased risk for bleeding and could change our judgment, especially with what I'm thinking about is heparin. So typically we think about heparin every 8 hours or every 12 hours. And typically we think about 12 hours in patients that are have severe renal dysfunction. However, when patients age, it could be appropriate to use every 12 hours in these patients just because they are at an increased risk for bleeding. So monitoring parameters, I talked about some of them, obviously. Anti-factor 10A or APTTs for enoxaparin, for Lovenox can be used, at least the anti-10As can. For heparin, we can use either one of those, with the anti-10A factor being more important. And then we obviously want to look out for bleeding or any kind of heparin-induced thrombocytopenia, especially with heparin, or to a lesser extent, enoxaparin. Another thing to look at is the indication. Why are we using this anticoagulation? Are we using it for prophylaxis? Are we using it for treatment? It's important to realize that dosages are affected depending on the indication, whether we're using it for treatment, which would typically be a higher dose as opposed to a prophylactic dose. And reversal agent availability, this is something newer since dabigatran just did come out with Praxbind or idarucizumab, so it now does have a reversal agent. Other than that, warfarin does have a reversal agent as well. And outside of that, really blood transfusions are going to be the best way to kind of go about it. So what do the guidelines say for treatment of cancer patients for anticoagulation? Really what they say is that low molecular weight heparins are preferred over warfarin, and they should be used for at least 6 months in a patient who have had or has had an acute VTE. Now, why would you treat it for 6 months, and why would low molecular weight heparins be preferred over warfarin? Well, the study showed that there is a decreased risk for recurrent VTEs in patients that were treated with low molecular weight heparins versus warfarin, although the bleeding risk was the same in these studies. So really what you're doing is you're decreasing the risk for another VTE while keeping the bleeding risk the same. Now, one thing to realize is that at least in hospice and palliative care, we have to look at every different avenue and every different aspect, one of which is being the cost. So warfarin, we have to do lab costs if we don't have the point of care testing. Low molecular weight heparins, we don't. So as well as the NOACs, we don't have to do testing. Now, these guidelines didn't really look at the NOACs, so it can't be extrapolated necessarily to those newer agents, but the guidelines do recommend using a low molecular weight heparin over warfarin right now. So in patients that have a short prognosis, really clinical judgment needs to be used to assess the need versus the risk. Most studies looking at anticoagulation use in palliative care patients exclude patients that have been on hospice or have a really short prognosis. So it's really hard to get good, solid data for patients that are in hospice to determine what is the most appropriate therapy. Usually it's going to be patients, it's going to be clinical judgment to determine that. And then you really have to assess if the treatment is going to increase quality of life. Now, we know hospice is all about increasing quality of life and increasing the time they have left, not necessarily increasing the length of time they have left. So depending on how long you expect the patient to live, do you expect them to live greater than a month, or do you expect them to live within a week? It's going to be important to look at these different factors and determining if anticoagulation is appropriate for these patients. Also, another thing to assess is, are they having symptoms? Are they having pain and swelling from a DVT that could actually be improved if they are on anticoagulation? All these questions have to be asked before you actually put on a agent, which I'll talk about if that's even appropriate to add an agent on in patients that have a DVT or PE that are on hospice. So looking at some actual studies, one study I'm going to bring up is and essentially is a 36-bed PCU or palliative care unit, which assessed use of anticoagulation and their risk. So you can see there was 127 patients in this study. Not all of them were on anticoagulation, but I do have a little diagram which kind of goes over what patients came in and if they were on treatment or not. So there were 127 patients that were initially admitted. 41 of them were on primary prophylaxis. Out of that, only 5 of them continued, and that was typically due to families' request, families fearing that the families would be very fearful or scared if we took away anticoagulation, and one of the patients was continued because they had AFib. As far as the secondary prophylaxis or VTE treatment, everyone was continued on that because they were currently undergoing some treatment for an active disorder. And then patients that came in that were not on treatment, no treatment was started prior to the stay in the unit. Now, this highlighted section in the bottom, this is actually during their stay. Everything above was completed within 72 hours. So you can see some were new started. So there's some VTE or anticoagulation was started. So 1 was started due to a new DVT. 2 were discontinued that were originally continued from the primary prophylaxis, and that was due to bleeds. As far as the VTE treatment, there were 7 that were discontinued, and that was either due to end-of-life care, bleeding, or family's request. And then as far as not on any treatment, there were 6 people that developed acute DVTs, which low molecular weight heparin was started in these patients. Essentially how this all went down is, go back. Okay, so there was essentially 87 or 88% of the patients that came in on anticoagulation were discontinued. There was a 92% cancer diagnosis rate in these patients. So the majority of these patients that came into the palliative care unit had cancer. They had a mean PPS score of 40% and a median. So what is a PPS score? So essentially, PPS score is a palliative performance scale, which is a useful tool for measuring progressive decline in palliative care or hospice patients. It has 5 functional dimensions between ambulation, activity level and evidence of disease, self-care, oral intake, and level of consciousness. And essentially within that, there are 11 different levels of PPS ranging from 0% to 100% in 10% increments. Now, every 10% decrease has a fairly significant decrease in physical function, as you can see and as you read across. It's really a good way, the PPS is a good way to help teams and interprofessional teams communicate with each other about a patient's prognosis and how well they are doing. So the average stay of these patients was 28.6 days with a median of 19 days. So these patients weren't on this unit for a very long time, and really it can almost be thought of like a hospice program because they were there for a very relatively short time before they were either discharged, which you can see only 12% of the patients were discharged, or they had passed away or deceased. So with the discharge rate and the average stay, it is largely like a hospice program that's in a palliative care unit. So what did they find? So out of all the patients, there was 1 patient that developed a symptomatic DVT in the study. So essentially 2.8%. The authors claimed, and I agree with, that it is justifiable to stop thromboprophylaxis in select patients, especially those with very advanced disease and those on hospice. Now, before you do that, you'd obviously want to talk to the patients and the families and get their intake on it. It's important to have everyone's buy-in before you go ahead and stop something like this. And it's important to let the families know that there is a risk for a clot if we stop it, but if we continue it, there's also a risk for a bleed that could be an intracranial bleed that could lead to death. So really, it's important to include the families on these decisions before just going ahead and saying that we're stopping. Now, one thing we can do is always transition. So if patients are on a NOAC, for instance, we could transition if the patients definitely want anticoagulation to something more affordable like Coumadin, especially if you have point of care INR testing. It would be important to use that from a monetary setting. Another thing that is important to realize is that this was performed in a hospital-like setting because it wasn't a palliative care unit. So it's not going to be like our typical hospices where we have patients at home, we have patients in the nursing home, and then we have a select patients inpatient. My hospice where I work at, we don't have very many inpatient or general inpatient patients. Most patients are either from a nursing home or at home. So the next study I'm going to look at is assessing Dalteparin versus placebo in advanced cancer. Now this was a little bit larger study. With 385 patients. There was an active group essentially receiving Dalteparin 5,000 international units sub-Q once daily for a year, or placebo. They did Kaplan-Meier survival estimates, which was not statistically significant. And you can see here the survival analysts. So patients that were on the Dalteparin actually had a greater survival. However, at the first year, there was no statistical significance. Now, greater than 1 year at 2 years and 3 years, it was statistically significant, increasing survival. But one thing to realize is that these patients, when we think about hospice, the whole kind of definition of hospice or a requirement for getting on hospice is that you have 6 months or less to live. So one thing to think about is, why is there a change in survival? Well, it is believed that the change in survival could be due to the effects of Dalteparin. It could have a reduction in silent fatal PEs. And really, another thing that could be beneficial is that experts speculate that low molecular weight heparins like Dalteparin, which is similar to Enoxaparin, may have some tumor modifying effects, which could lead to the benefit. So it could actually have its own benefits on the cancer, which could lead to benefit. Now, when we look at different statistics in the study, so how many patients had a symptomatic VTE on this study? So there was 2.4% of the patients that had a symptomatic VTE on the thromboprophylaxis or on the anticoagulation, while 3.3% on the placebo did. Now, other thing to look at is the bleeding rates. So 4.7% of the Dalteparin patients had a bleed. So there was a total of 9 bleeds. 8 of them were minor, but 1 of them was major and it was fatal. As far as the placebo went, there was only 5 minor bleeds, none of which were fatal. So something to realize about this study is it was underpowered. You could see that it did have more people in the previous study, but essentially the results of this study indicate that that it really has to be assessed patient by patient. And really the risk at 1 year, there is no statistical significance at assessing. So as far as the number needed to treat, you would need to treat 190 patients, 190 advanced cancer patients to prevent one symptomatic VTE. Now, if we did this on every patient that came in with advanced cancer or VTE, it is estimated that would increase drug costs by 28% in a hospice. So that is a very large increase for spending. Not only that, but you're going to have more bleeding. As I indicated, there was a number needed to treat of 3.5, so round up to 4. So what you're going to do is you might decrease one symptomatic VTE if you use a low molecular weight heparin in patients. However, you're going to have 4 more bleeding events, and you're going to increase your costs of medications by 28%. For instance, for our own hospice, in the past 6 months, we've had 4 Enoxaparin prescriptions. Each of these Enoxaparin prescriptions were over $500 per prescription. So even though the Enoxaparin only makes up 0.06% of our overall prescriptions, it makes up over 1% of our prescription costs, which is very significant for something where there's only 4 prescriptions. So what is the verdict on thromboprophylaxis in hospice patients? Well, the recommendation I would make is don't initiate or offer thromboprophylaxis in patients on hospice. Now, you can talk about it if they come in on thromboprophylaxis or if they already are on anticoagulation, but it's really important to consult with the families, consult with the patient, and see what their goals are, see what their thoughts are, and see what they really want. Are they more worried about a clot or a stroke? Or are they more worried about a GI bleed or an intracranial hemorrhage that could lead to death? Either one of them is dangerous. Neither one of them has their own risks. So it's going to be important to include the family on these decisions when looking at it. I would recommend for the majority of patients, discontinuation of therapy would be appropriate. However, if patients and families wish to continue, I think that's also appropriate. In my clinical judgment, I think that most of the time they should be discontinued, but as I said, it's important to consult the families in determining what the most appropriate action is in these patients. And I'm done. So any questions you guys may have, I will open it up to you. I see there's, oops. Thanks, Chris. I don't know what slide you're talking about, but I appreciate it. So what questions do you guys have?
What are you all doing at Hospice of Southern Illinois? Are you maintaining them on low molecular weight heparin, or are you switching them over?
We typically switch them over to Coumadin. It's more cost affordable. We have a point of care INR device. We'll get INRs between every 1 week to 2 weeks in these patients to assess. Now, obviously our goal would be to get them off of the medication, but we have very few Enoxaparin or low molecular weight heparin patients. The only time we really do that is if it's a physician that really requests it, because I mean, the data is there to say it's more beneficial, but it's very rare that we would actually use low molecular weight heparins just because of the cost alone.
I'm just asking this out of my own curiosity, but so how do you all maintain kind of quality assurance for your point of care, like coagula check or whatever it's called, that you're doing in the home? Do you all do periodic comparisons against venipuncture?
You know, that's a question that I have not asked, so I do not know. That's something that I can definitely bring up and see how they are making sure that that is okay. One thing that was recently brought up, which was somewhat fearful, is that it got brought down, which we think isn't a problem, but potentially not being able to do INR testing at the home because it's a blood draw where it need to be done in the lab. However, it should be CLIA waivered, so it should be fine that we can continue to do that. But
And I'm just, based on your research of this, you know, the Clotting Cascade and what you know about patients at the end of life, is the INR an accurate, is it an accurate surrogate for a patient's actual bleeding risk at the end of life? Is that the best lab to be looking at?
Overall, I would say no. I mean, around 50% of the patients on hospice have cancer. Many of them have metastases, especially patients that have metastases to the liver. They are extremely hard to control their INR levels because that's where the clotting factors are formed. Not only that, but there's more to it than just clotting factors that increase their bleeding risk, their age, their fall risk. Really, I guess the best thing to assess for an actual bleed obviously would be looking at hemoglobin or symptoms and signs. But right now with the Coumadin, the INR is our best option outside of getting a hemoglobin to make sure they're not actively bleeding, at least looking at their risk of bleeding. Now that has to be taken with a grain of salt because these patients are aged. Their dietary changes have a huge influence on that because a lot of times as they progress down hospice, they lose that hunger, they lose that want to eat anymore, so they stop eating less. Now, if they ate a lot of green leafy vegetables before, that could have a huge increase in their INR. It's very hard to control these patients' INR or patients' INRs when they are on hospice on Coumadin.
The peanut gallery is silent today. Nobody else? All right. Well, Brad, you'll be happy to know that I've sent out a request begging for other people to help. So I'm assuming we had kind of a light turnout today because of the upcoming long weekend, but
Yeah.
Please don't let that detract from another wonderful presentation. We sure appreciate it. I learn something every week, and I'm sure the rest of us tuning in do as well. So thanks, and I hope everyone has a wonderful Labor Day weekend.
Yes. Hope everyone